Good morning to all of you. And thank you very much, Dr. Lakshmi, for inviting me to present myself on this topic as far as embryology aspects are concerned. It's an amalgamation between embryology as such, and we have cherry-picked the topic of semen analysis because today you all must be surprised that when we are doing advanced techniques, when we are doing CRISPR, when we are doing biopsies, when we are doing invasive, non-invasive, why do we still cherry pick a simple single cell like a sperm? Because you know that the success of embryology depends upon the development of a good embryo. And the development of the embryo subsequently leading into its proper implantation is nothing else but a manifestation of its genome. Embryo is what? It's a formulation phase between the largest cell of the body and the most sensitive, that's the oocyte, vis-a-vis the smallest and the most motile, that's the sperm. And many techniques of ART depend upon the sperm actually which is from vivo to vitro. Say like an IUI, insemination, AIH, artificial insemination husband, or even a simple process basically like an IVF, which is a natural selection. Now that all depends upon how well the sperm is selected, the sperm is capacitated, and subsequently the processes which follow. A well-processed, capacitated sperm will enhance your success rates by at least 15 to 20%. It is really a dynamic cell, but it ought to be treated carefully. And the sad part is today at many places where the concept of ICSI for all is noted, believe me, scant attention is paid to semen analysis. It is just like how many oocytes you have, find that much sperm, inject it, and let the story go on. Because when we are judging the developmental pattern of an embryo, or what we call it as embryogenesis, what do? We are monitoring it just like the milestone of a child developing. Different stage of development at different hours, like the formation of a zygote at 18 to 20 hours, 2 cell at 26 to 27 hours, 4 cell at 38 to 42, subsequent morulation, three stages of blastocyst development, capacitation, expanding, expanded. So if you start a procedure on Monday, you get a blast development by Friday evening or Saturday morning. Now all these things would not have been possible unless and until both the gametes with their genome intact, with their small biological concept, would not have been to success. Now here I would say so. Why is a sperm more important? Because yes, it's a dynamic cell which makes its way forcibly into the ooplasm. Naturally, IUIs, IVF, and assisted, it is by ICSI. So the challenge in ICSI also lies is when to select the right sperm and how to select the right sperm, for which today we have got a number of add-ons available. Like IMSI technique is there, sperm sorter is there, microfluidics is there. But till today, you cannot say with authenticity which is the best sperm, which is the best oocyte, or which is the best zygote, because all the techniques which we have been utilizing, they are dependent only on the observation, morphology, cytology, and the appearance. None of these techniques are responsible for finding out the actual genome of the egg or the embryo. But anyway, whatever we have got, we have tried to implement in the best of the best ways. So this semen analysis, basically, the first thing when a couple walks into your lab, and this for infertility, before even touching the female as such, what we got to do is request the gentleman to give a semen sample, do a spot observation. If it is to our satisfaction, half of your battle is won. But there will be only one small lacune. Semen analysis predicts everything except the fertilizing potential of the sperm. because that's basically the genomic part. Therefore, sometimes diabetic males, excellent count, excellent motility, dynamics, kinetomatics are fantastic, but still the fertilization is compromised. But there are some very rare cases, or that person has some severe genetic aberrations or genetic defects. Okay, so I'll just start the presentation. If you want to interrupt me in between also, you can do so. Let's make it a monologue, not a dialogue. Okay, fine. So this is exactly a peep into the history as such. Previously, there were nothing like a detailed analysis report. It was not a formulated version, because this is the time frame how slowly the development techniques started taking place. It was what that the semen sample was observed. Some were saying a lot of sperm, some were saying quantity is more, quantity is less. So therein came the count. Some were saying, oh, the volumes are fluctuating. Thereby came the importance of the volume. Some were saying the way in which the cells were moving. So then came the kinetics into it. Then came the shape. So all these parameters amalgamated together ultimately formed a standardized semen report. And later on, we started interpreting them as per the problems faced by the couple. That, oh, infertility is there, in this case, this problem is there. So, it was like a sense of correlation. Now, this is what I was telling you. Here, I think the pointer is not showing properly over. Anyway, bulleted number 3, all the external features. Guidelines are there today. WHO assisted guidelines. They will tell you everything A to Z about it. But year after year, or after every 3 years, the guidelines seem to modify themselves. So there is a slight alteration. There is no standardized by default, okay, this you have to stick to it, hook, line and sinker, or this is the ultimate about it. So this is what exactly we do. Standard procedures, research-oriented procedures, and optional tests, which we are doing as far as analysis is concerned. Now, optional tests are not the foray of any andrological laboratory, but microscopic examination, spot observation, and research procedures are also difficult, because let's say, for example, initially it was the hamster oocyte penetration assay. But unfortunately, we can't import hamster eggs due to our restrictions in our country or the import policies. Then next comes is, before your hormone assays, what we were doing? We were doing biopsy studies, just to study the structure at the tissue level. We were doing testicular biopsy, fix it, and at that time the fixative used in all reproductives is Bowen's fluid. Means you can't use alcohol, nor can we use formalin, because they will cause a sudden shrinkage, and this will lead to differences in histopathological observation. So depending upon the layer of cells, we used to grade them, or what we used to call them as a testicular biopsy score. Nowadays, high FSH, high prolactin, case of infertility, or a male reason. But this is exactly what it was studied at the tissue level. So whether cells were there, Sertoli cell syndrome, presence of spermatids, which stage of spermatid, it needed a careful interpretation. But believe me, it gave a good outlook at the tissue level. So we were exactly able to find out. We were to read nearly 200 tubules, take an average out of it. Because when you see a testicular section, you will see a number of seminiferous tubules. And believe me, out of 10 tubules, 5 will show a state of arrest, but that's not arrest. That is, they are in a state of rest. Because in the subsequent cycle, they will proliferate and the sperm production will be enhanced. Spermatogenic cycle, 68 to 74 days. That's the reason any andrological treatment extends to at least 3 to 4 months, so that at least 2 of your cycles are being targeted by the drug. Now these were your guidelines. Now in this you can see everything is quite the same except the normal forms, 50, 30, 14, and then it has dipped to 4. So this shows that currently, as far as predicting the fertilizing capacity of the male is concerned, It's the morphology and the shape that counts. But it is not responsible. Morphology plays a certain part till the sperm, number of sperm digests the zona or the cumulus cells. One lucky sperm does the membrane reaction, enters the perivitelline space, nestles over there, cortical reaction, prevents the other sperm from entering, prevents polyspermia, and the shape when it touches the oolemma, that is important because the head acrosome is a pyriform shape. There is a selective contact area between the acrosome and that nuclear envelope. That triggers off a mechanism, then the sperm goes and fertilizes, contrary to our belief that it goes tangentially. So that's why the shape of the pyriform head or the acrosomal cap is of prime importance. And this is very susceptible. It is now just 4%. In the most fertile man, sperm being normal in shape are just 4%. Though we are not having a standardized technique by which we can exactly cherry pick that this is the ideal sperm. All this is a little bit of a probability with a bit of question marks. Now imagine in case of OAT sample, oligoasthenoteratozoospermic, multiple parameters are at fault. You will not find a single normal sperm. Now in this case, if we want to do ICSI, how are we to choose the sperm? Randomized. We just cherry pick what is seen to our eye. Agreed. There are technologies like IMSI, intra-magnified sperm injection. It was an objective which will magnify a sperm to 7,000 times. But still, it is not guaranteeing you that this is the ideal sperm. Because our human eye is not able to suspect or detect the best of the best sperm, just as in an embryo transfer, we are not able to detect the best of the best embryo. So that's the reason many a times in ETs, we must be surprised that the worst looking embryo has given you the pregnancy and the best looking embryo in which you have betted all your last rupee in your pocket has disappointed you. Even in semen wash, post-wash recovery, sometimes counts less than 2 million have given you results, whereas count more than 15 million have disappointed you. But in those 2 million, the kinetics were excellent. The motility and the progression was excellent. So today also in a normal semen analysis, when we see an analysis of a crowded city or a metropolitan city where the males are inundated by stress and all this trauma, 70, 80 million is tolerable. But when you go to a class 3 or class tier city or a village area, counts are hyperzoospermic. But there is infection, unhygienic sanitary habits. So today I would say I prefer a count with less, but it is clean rather than a supersaturated count with infection. Because though our techniques are there for washing, they cannot totally eliminate the bacterial infection or the viral infection which presents in the seminal plasma. Okay, this I'll take when we come to the techniques of washing. So these are your guidelines, all available on the net. This is just a general criteria. How the morphology looks like. One is by Strick's criteria. We have got the staining technique. They were invented by Dr. Thinners Kruger and Daniel Franken of Teiberger's. So therefore the Teiberger's staining criteria, and one is the WHO criteria. Mostly both of them are falling in the same line. Now when we judge it, basically we divide the sperm into 3 parts: head, midpiece and tail. Each has its different function. Head is what? Concentration of DNA. Midpiece, mitochondria. Tail for locomotion. But for a proper functioning of the sperm, all the 3 parts amalgamate together. The dynamic head, minimal resistance in a normal condition to a well estrogenic cervical mucus. It just zooms across because a good estrogenized cervical mucus is the best filter of the sperm. In our case, in our lab, the mucus is substituted by our media. So the most important thing, the pH, temperature and the osmolarity are the basic important points which will help the sperm to survive, because ART tells you what? Recovery of gametes, processing of gametes and survival of gametes. It should three go in a linear direction. Because here, the midpiece generates ATP, adenosine triphosphate, energy which passes through the tail. Tail is a locomotory organ. At a section of the tail, it gives you 3 plus 10 plus 2 fibrillar arrangements, dynamic motion, effective stroke, recovery stroke, and the sperm progresses. The aerodynamic shape minimizes the resistance. So you see how the three parts work together. That's the reason when we do the sperm morphology, divided into three parts: head abnormalities, mid abnormalities, and the tail abnormalities. Now if such good quality sperm are harvested, transferred in an IUI, bypassing the cervix and the vagina, minimizing the loss, enhancing the travel part, inseminating them closer to the time of rupture, all this, what does it do? It doesn't enhance pregnancy, it enhances fertilization. Now pregnancy and fertilization are two issues. Once the zygote is fertilized in the tube, it will travel all the way through the tubes, different areas, different zones, developmental process depending upon the secretions, till it pops in the uterus, implants, and then a pregnancy is there. But if fertilization is enhanced, everything being normal, definitely your chances grow. That's the reason today, non-indicative cases in IUI, the pregnancy rates are as high as 22 to 25%, compared to 5 to 12% in indicative cases, because psychosomatic stress. That's the reason about it. So it really plays an important part on the culmination part as far as the male gametes are concerned, the production and subsequent our processing part. Because what we are doing is, when we harvest them from vivo to vitro and when we culture them, our main aim is to provide the same conditions which were present in vivo. So that's the reason where your lab setup and equipments will come into play. Now here in males, mammalian, especially humans, the sperm DNA holds a very vital part, because in the acrosomal head, it is compacted 5 to 7 times. It's like a bulk. So the moment it enters the ooplasm of the oocyte, it suddenly bursts open, or what we call it as decondenses. And this decondensation is a very vital step prior to the formation of your zygote. Quality of the ooplasm, so quality of the egg, quality of the sperm, quality of the DNA, it will enhance the formation of a good pronucleus, or what we call it as a zygote. Essential step prior to the first 2 cell, which is a clear-cut indication of the individual to be born. So in your embryology, when we say the culmination of the 2-cell stage at 26 to 27 hours, the quality of the embryo which is formed, which is a direct reflection of the genome of the sperm as well as the oocyte, which in an IUI, unfortunately, we are not knowing, because one is in vivo, one is in vitro. That's the reason 4 cycles back to back will definitely enhance the cumulative success rate. And I think in this last figure, there was a very nice article written that today, successes in IUIs are much more towering than successes by normal ART procedures. Because what we feel is, any patient who comes, a little bit of wishy-washy semen analysis, recruit them for IVF ICSI. No. IUIs also do work the trick, provided we have the patients first to test, stimulate, read the patient's indications. It is not only in females that the indications are depth in detail, even in a male the indications have to be depth in depth. Then only we can come and counsel. So this is the breakup which we decided, or which we just discussed. These are the general parts, the more biological issues which are too, I think, intricate, so let's skip them. Now this is what a good analysis report should be including. Right from the patient's identity to the date, to his history, to the medications. Now important part is, this is not like blood collection that we poke in the hypodermic and pull out what it is and then subject it to a micro analyzer and get the results. Collection is a mixture of stress, tension, apprehensions, anxieties. It's like a white coat hypertension. Normally a gentleman would give semen in a flash, but on the day testing is there, he gets into stress. Performance is reduced. And with the performance being reduced, the output is compromised. Correct? And this is very vital. Now suppose you do an analysis number 1, you get very poor count. That doesn't mean that he's an ICSI patient. Order and collection after 15 days with a 3 days abstinence, it may shoot up to 40 million. So ideally, 3 analyses have to be done with a gap of 15 days and 3 days abstinence prior to each collection. Believe me, it really plays a great difference. Now suppose if you are hell-bent on thinking that मुझे तो उसकी ICSI करनी है, तो automatically your reports would say 2 million, चलो डाल दो ICSI में, simple as that. Because after all, you have set up your lab. Definitely, so you have to run the show. But the patients will promote your name as an infertility specialist by the simpler and the cheaper procedures by which she gets pregnant. And IUI really is very important. I don't understand why people are simply avoiding the IUIs. The reason is because they are not in a position to wash the sperm properly. Now, monitoring of your follicles is by sonography and your hormones. Here you get a sample ready, available, at demand, anytime you want, whenever, wherever you want. But the patient's anxiety. So collection. Now collection is also important because many people have a situational anxiety. They say, I won't be able to collect in the lab, I want the comfort zone of my residence. Fine. 2 things you have to be careful. The contact of the sperm with the seminal plasma, that's very important, because if the sperm are in the seminal plasma for more than half an hour to 40 minutes, 95% of the fertilizing capacity is reduced. So please, whenever a home collection is there, tell them to get the sample as quickly as possible, but usually they don't tell us the truth. Fine? The container in which they collect. Provide them with a sterile laboratory container. We all know that years ago we were using glass bottles for everything. Saline bottles were glass, hypodermics were glass. Why? Glass never reacts with any biological fluid. Because glass is not a solid, it is a super cool liquid, or what you say, it's a vitrified liquid. But then there was a question of washing, sterilizing, drying, etc., etc. So we got with the plastics. But all this infertile procedure plastics or disposables, what we call it as, they are also styrene and styrene, so they are chemical pollutants. But when they are manufactured, care is taken to see that the reprotoxicity is as good as 0. That's why we have the CE certification labels. Mouse embryo toxicity labels means in those batches, mouse embryos were cultured till blastula. Then only the way they are packed, the way they are sterilized, whether ETO sterilized, gamma radiated. So this is all important. So give the patient a collection bottle from your lab. Now in home collection there is one risk, sample substitution. People used to get somebody else's sample. And it was noted. So what we used to do, we had a format that we, Mr. and Mrs. blah blah blah, have collected the sample at home to be processed in this lab for an IUI on this date, signed by the wife and the husband together in front of each other. Because if the husband says, मैं wife का sign लेके आऊँगा, तो God knows वो किसका sign लेके आएगा, वो भी तुम्हें पता नहीं चलेगा. So this is a very risky factor. Because if a pregnancy takes place and then these nuances formed, ultimately nowadays the lab will be blamed. So in a sense of, I would say, parental witnessing, both should be aware of the procurement of the sample. That's the reason we always advise that please enhance or advocate the patient to do the lab collection, provided the lab has a good collection room. Because sorry to say, 6 out of 10 rooms which I had seen in my career are not only toilets, but I could say pathetic toilets. It's a disaster. And what is the first thing a gentleman has an apprehension? Somebody knocking at the door. Time frame. So you tell them that we always notify, collection going on, don't disturb. And if a gentleman can't collect in the first 40 minutes of masturbation, he will never be able to collect a sample because of the negative inhibition which sets in, however hard he tries. And the harder he tries, you can't do subsequently a TISA-PISA also because the musculature of the epididymis will go flaccid. So there won't be a chance to even retrieve the epididymal sperm, howsoever turgid the epididymis looks like. So these are the nuances. Okay? Then comes spillage. Counsel the patient properly because the first squirt has more than 40% of the most motile and active sperm. Patients क्या कहते हैं सर शुरुआत का हिस्सा गिर गया आखिरी का हमने बराबर से collect किया है. No, it should have been the other way around. Because the first squirt is a manifestation of the testicular ejaculate mixed with the prostatic and the bulbourethral secretions. The last, which contributes to the volume, is an offshoot of the seminal vesicles, which contributes to the volume in the large extent. So pH-wise, bulbourethral is acidic, prostate is acidic, and seminal vesicle is alkaline. So based on the volume and the pH, subsequently if we have to send a patient to an andrologist for observation, these play a very important part. So these initially cherry pick points which we check, these are known as spot observations, which will help you to give a very small abbreviated report. Now you do a first analysis, just a spot observation, fantastic number of sperm all zooming together, 50% of your stress is relieved, male factor is out. Then you can still do some cherry pick tests like how we used to do, at least 2-3 analysis, one trial swim up and one 24-hour survival test. These are the basic tests you should do for a male before recommending him for even a simple procedure like an IUI. Because sperm processing, whether you do IUI, IVF or ICSI, is basically the same, or what we call it as sperm capacitation. Okay? Then volume, color, as I told you, pH. Now odor, unfortunately, STD infection, bacterial infection, very foul odor. Motility kinetics we'll discuss in the coming thing. Count, that's the most important part. Count mein yaad rakhna hai, what you call it as count million per ml, million per ejaculate, and total motile sperm count. Now let's say 80 million count is there. We are very happy, fantastic, because whenever we ask a report on the phone, what do we say? Bhai report kaisa hai? Arre count to badhiya hai sir. Then comes the punchline, motility khali 10% hai. So in an 80 million count with 10% motility gives you how much? 8 million productive sperm. Now from that 8 million also, you have a breakup. Active, moderate, sluggish. Initially it was written like 0, 1, 2, 3, 4. Some were giving in ascending, some were giving in descending. Then came the text form, active, moderate. But now WHO has found only 2 criteria, progressive and non-progressive. But believe me, even from 10 million motile, the real best ones come to the tune of 3 to 3.5 million. The rest are sluggish, moderate. You got my point. So just like in your egg recovery, eggs recovered, how many metaphase 1, how many metaphase 2, how many germinal vesicle, how many empty follicles. So what you see on the sonography, what you recover, post denudation what you get, the tapering is up there. So basically in all these biological samples, the base has to be quite strong. It's like a tapering pyramid. You got my point. Then another thing is cellular inclusions, premature cell, pus cells, epithelial cells. If there is coitus interruptus, then lots of epithelial cells are present. Fructose, the only biochemical test which we can do in the lab. It's a presence of a nutrition medium because sperm breathe anaerobically. Now you can remember one thing, temperature sensitivity is very important. You will say that post-ejaculate we always incubate the sperm in a test tube at 37 degrees. Whereas in the human body, they are in scrotal sac away from the human body to prevent the increase of temperature. Because in the initial phase, the high body temperature can deactivate the DNA present in the acrosome. Agreed? But post-ejaculate, it's a fully mature sperm which needs 37 degrees for activation. Activation starts from 34, peaks at 37, but if you still increase the temperature, the motility will still crash down. So hypo and hypothermia are basically very bad. So coming to that point, There is just one terrestrial mammal which has the testes inside its body cavity. Can anybody name it? It's the elephant. Male elephant doesn't have testes outside the body. Elephant always has the testes inside the body. It is insulated by layers of fat. So the thermoregulation is managed by the layers of fat. But in all male mammals, it is the other way around. Okay, so these are the important points to be noted. These are certain diseases or genetic disorders, hormonal imbalances which can affect spermatogenesis. So again, history taking is very important. Medications which impair spermatogenesis, and most important are occupation hazards. Now that's the reason. Many are coming up with secondary infertility. Why? Because once they have a child, they have a little bit of relaxed life. They tend to spurge a little bit, especially executives and all, sitting whole day, tight jeans, fashionable, cross-legged, laptops on their bench, going home, hotting hot sauna baths for hours together, basking in the water at 87 or 80 degrees. That affects spermatogenesis. Or in routine people, workers, rickshaw workers sitting on the hot engines the whole day, furnace workers, cooks, exposure to temperature perennially. In the longer run, they're really affected. Because a spermatogenic cycle, as I tell you, is 70 days long. Initially, if the spermatogonia A and B are affected by the heat, by the time they promulgate to the stage, the whole cycle is compromised. So the back sperm or the back spermatogonial elements which are regenerating also will be compensated. So please give them a good recovery time. And most important for the motility is tobacco, cigarettes, nicotine contamination. Nicotine contamination compromises motility. What we call it as lazy cilia syndrome. Abstain from smoking for at least 2 to 3 months. Keep him on vitamin E. Motility improves by at least 40%. So whenever certain parameters were wishy-washy, can we switch off the fan? I think it's creating a lot of noise, if possible. So whenever we used to give, our little therapy was what? B complex with zinc, then vitamin C and vitamin E. So suppose if nothing is wrong with the male and still we don't treat him, now what do they feel? No, they didn't even treat me. I don't think so. This doctor is good. But if we give them some placebo-like treatment, but it really works also. Don't forget that. It really improves your result as such. Plus the psychic. The psychic tension is out. So this is how we generally categorize. Normo, oligo, astheno, terato, necro, azo, oligo and aspermia. Aspermia means no semen per se. Azoospermic is no sperm in the semen. OAT is a manifestation of all the three put together. Correct? Just like ovulation, anovulation, etc. PCOS, more number of eggs but poor quality. The same way the sperm is there. Now this is what exactly I told you for collection. Now another point is what? Where the gentlemen get a little, I would say, frustrated or dejected. And where do we not touch a little bit of ethics? A common waiting room, a sister coming and shouting, so and so, semen collect karke aao. No, that's rude. Now if it is for blood collection, it's okay. I'll happily go, that's your turn. But then it looks it's like humiliating. So if you really wanted that, because already on that day, what's the biggest apprehension of ART procedures? The cost factor. And compounding the cost factor, the results. So many times people argue, sir, price kitna hoga? Let's say for an IVF procedure, we say ₹1,00,000. And what are the results? We say, well, 30%. They go, ₹1,00,000 dene ke baad bhi khali 30%. But we explained to him that you stand in the 30% bracket, otherwise you would have had a 0% chance. No, that's true, because if that 30% also is not affiliated to, but sometimes when people are on the borderline, constructive counseling also is effective to 5 to 7%. Because many a times, I have seen some people read the report, when they read the report, they shrug their eyes, that verbal Then they take out their pen, they mark something, they scratch something. The patient gets apprehensive, sir, what happened? Something wrong? No, no, sab kuch theek hai. Believe me, the patient will never come back to you. Because he will feel that the doctor is hiding something. Now this is so depressing because the sad part is, in our country, infertility is committed like a crime. Now let's say, for example, you have attended your friend's wedding 7 months back. Yesterday you meet him on the road. What's the first question you ask? Hey, kuch good news hai kya? Right? And if he says no, we look at him in such a way that he has created a murder. And then we start counseling them. Kuch problem hai to mujhe bata. You know, it's that. Now he feels apprehensive as such. He feels dejected, frustrated. He feels like, let me walk off this person. Now this creates some more and more stress. Not only to himself, it causes difference of opinion between two partners themselves. Now suppose one is at fault, one is normal. The one who is normal will always blame. In the public function, they'll be homogenizing as a lovely couple. But once they go home, the apprehension starts, see, because of him, I have to take the insult. Because we Indians panic 2 months after marriage or 10 years after marriage. In between time, all these extra nuances we keep on practicing, which inadvertently harm our endocrines. You got my point. So the saying is, stitch in time saves none, because going to an infertility is committed as a crime. What will people say? If somebody sees me, what will they answer? So, in many tier 2, tier 3 cities, when centers were set up with the best of the best facilities, people used to go to places away from that. Koi dekh lega to kya bolega? So till that nuance is broken, unfortunately, it is very difficult to counsel the patient. And compounded by the high cost and low results, this procedure still becomes a challenge. But at least now I feel the taboo is broken and more people are coming out. But still they expect the sun and the moon. So this is the thing for sample collection. Now, these are various methods. Masturbation is the best. Okay? Coitus interruptus, well, but in 90% of the cases, people have missed the first squirt. Because it's literally impossible for the gentleman to make a decision at that time what to do. It's like once you have pressed the trigger button of a nuclear missile, you can't say I'm retrieving it back. It's impossible to wait that. Once the missile is out, it's out, finito, till it does the damage. Then PVS, I'll show you the figures, and electroejaculation. In what issues we can do that. So a lab should be having a little bit of SS gadgets like a vibrator or a handle vibrator or a massager in case of collection issues. Now what a male has to face during sample collection? Anxieties. Anyway, thank you. So what the male has to face is, because we sometimes create our own attention. On the day of the procedure, what we tell them? आज procedure है, final day है, बराबर collect करना है, भाई उसके हाथ में नहीं है वो collection करना. So instead of boosting his morale, we sometimes depress him. We tell him कि listen, see, sometimes people used to ask us, sir ये ठीक तो होगा, and I used to tell them, those were those days, कि आपका सर दर्द होता है, पेस्प्रो लेते हो, ठीक होता है ना, हाँ, इससे भी ठीक हो जाएगा. And tell them, if I'm not able to collect on the day of an IUI procedure, it's not the beginning of the Third World War. Go home and have normal relations. So you have to just boost him up, though in our heart of heart we know, okay, well, it's not the ideal thing we are advocating. But what we do, this procedure in ART needs proper counseling, comfort zone, frankness, transparency, and ethics. If a patient comes to know about these three things, even if she has failed 1 or 2 cycles, she will come back to you once again. You know, okay, whatever it is, the doctor has told me the truth. So counseling is very important part. Out of 10 patients you counsel, 3 will walk away. Why? Because you have told them the truth. Because today people are Google savvy, litigation savvy, and they believe your neighbor. Nowadays, sorry to say, you breed your own competitors. In a nutshell. So even if you are having the basic things, नहीं sir, उसके पास तो ये भी है, आपके पास ये नहीं, आपके पास pregnancy नहीं हो पाएगी. So this was the, I would say, yardstick which many people are utilizing. An expensive lab doesn't mean towering results. As a matter of fact, I have found the ulta. The more high-tech gadgets you utilize and you are overexposing your gametes and not utilizing it to the best, you are causing them much trauma. You got my point. Be simple, stick to the basics. Understand the physiology. So treat the cell as a cell first before distinguishing them as a sperm and an oocyte and an embryo. Okay? So this is a collection room, the constituents, what it should be. Don't put soap. People use it for lubrication. Create a homely environment. Assure them there is no knock on the sign on the door. And your collection room should be away from your waiting room, away from the hubbub of the eyes, because when you say Mr. So-and-so, automatically all the eyes will go to you. And the patient feels apprehension because already वो बेचारा stressed out है. ऊपर से आप लोगों ने उसे stress out किया है. Correct? And the gazing eyes of at least 20, 40 people sitting in the consulting room. So this is what the abstinence period is important. It is a time between two collections which is aimed to improvise the sperm concentration. WHO has stated a very long time, but now it's not advised. Now 2 to 3 days is the best. Now when we tell the patients why the abstinence, what they do? They quietly keep it for 10-15 days. Because sir, ज़्यादा time रहेगा, ज़्यादा sperm बनेगा. बनते हैं, no doubt. The sperm count increases, but the sperm becomes senescent. Because your chorda becomes turgid. So explain to them the nuances of less and the nuances of longer abstinence period. Okay? That's very, very important. But still, prior to collection, always tell, because sometimes they have an uncontrolled nightfall on the day of the prior to one day of the collection. Note the reason. Otherwise, you'll say, "Tera to hamesha badhiya count rehta, aaj kaise aisa ho gaya?" First, they will hesitate. Then when we tell them, listen, we have to notify because this is going to be interfering with your procedure. Then they open up. Nahi sir, ratri asa zala hota, I had a breakthrough fall, or I was in mood yesterday, so I had relations with my wife. Well, your mood was there, your 30,000 goes waste. Simple as that. In a nutshell, you can tell them. So please prior counsel them properly, because when sometimes you have to be a little rude and crude. You cannot be cherry picking every time, and you cannot be a goody-goody with your patients, because those patients with which you are very, very goody-goody, if your results don't come, they become your staunch enemies. Okay? So this is the issue with lengthy abstinence. Actual biological points. What happens if your ROS, nitrogen reactive species increases? Count will go high, quality will go low. Okay, fine. Now, some people have a little collection issue. They have an erection, they try manipulating, but what we have is just a dry orgasm, means they can't get the semen collected. Because the proper excitation or the orgasmic phase is not reached. So it is just a simple vibrator. It's basically a body massager, which you have substituted. हाँ बराबर है? Okay, fine. Now this is a very handle stuff. Tell the patient to masturbate. He will go into a semi-erection. This is placed exactly below the shaft of the penis where the nervation is very high. Start it, mimics an orgasmic phase, and believe me, very, very successful, 70 to 75% of the times. And the patients which have never experienced this feel will be so happy that they end up buying the gadget. No, but tell them, don't thrust the equipment on the day of the procedure. Ke lo isse try karo. Bolega, sir, kya karne ka isse? So tell them to practice this in the peri-ovulatory period. This is a very good gadget. So it will remove his apprehension. Otherwise, he was still in the apprehension of what? He will never be able to ejaculate, so he will never be able to start a family. But seeing this condition, getting an ejaculate, telling him that the quality of the ejaculate is good, the count is good, etc., etc. We have to motivate the people, simple as that. Just like when we were children in a school, the subject which we used to hate the most, we would think we are definitely going to fail. What our parents used to do? Nahi, jara aur padhai karo beta, pass ho jayega. Then we think, sala minimum passing kitna hai? 100 mein 35 na, 35 to milna chahiye. So something, this was a deadline we used to set for ourselves. So here motivation is very important. Or electroejaculation in gentlemen, paraplegic, waist down, spinal nerve severely affected. Spermatogenesis will be normal, but the nervous system is compromised, so ejaculation is totally zero. This is an electroejaculator, inserted, okay? Start under the observation of an andrologist and an anesthesiologist. Patient is under anesthesia. Slowly it is given. Voltage is increased till 50 milliwatts so as to prevent the rectal burns. It comes in gasps. You can't repeat the procedure off and on. What is collected, instantly use it, cryo-freeze. Because mostly in this, the sperm motility is always compromised for some unknown reason. Count may be excellent. So these are just basic sample tips and tricks, which we all just discussed. All are given in that manual, but I have just cherry-picked and written them into a bulleted form so it's easier for you to understand. Okay? Fine? Then you do a spot observation. Take a drop. Most collection, don't send the gentlemen away because they are always in a rush to go away. Let them wait. Check a drop. You see certain characteristics justifying to your satisfaction, then tell them, okay, you can go. But if it is very poor, you are sure that you can't do a semen wash, the recovery will be very pathetic, ask them the reason. Then slowly, slowly the beans will spill out. Nahi sir, barabar hua nahi. The first part got spilled. Abstinence was 0. So you have to write down the reason. Now in a report, which otherwise a gentleman had 60 million, on this day it is just 2 million, you can write down. Spillage of the first part, no abstinence. So at least now you know what is what. So you can't use any other parameter for blaming of this. This you all know, I'm not going to enter. Now this is important. The secretions, their quantity and their pH and all the inclusions in the sperm. Now this is important from an andrologist because once he sees you or he tests you, suppose there is what we call it as cryptozoospermia. Now cryptozoospermia means what? A very poor count, extremely poor. Semen sample, every semen sample will not register a sperm. It will be 2, 3, no sperm, suddenly one lab will show sperm. And that lab will say, देखो sperm तो है, उन लोगों को देखने नहीं आता है. Then there's an interdigitation discrepancies. But this is a normal condition in case of OAT patients. Because today it is a crime to write anybody as azoospermic. Even a single sperm cited means he is producing sperm. Now you know the sperm testiculars, long tubule, nearly 60 meters in length if you stretch a tubule. One part will suddenly show proliferation and on that lucky ejaculate, you will find a few sperm. So when you get such a sample, lots of cellular debris, but you can't see a sperm, spin the whole sample. Check the pellet. In the pellet, you will find 1 or 2 non-motile sperm. So what you got to do? Write a text report that no motile or non-motile sperm seen in the wet ejaculate nor in the centrifuge pellet. Kindly repeat the analysis to confirm findings. So when it goes into some opposite person's hand and he sees a sperm, so he cannot contradict you. If it is present or not present, write both the options open. So this is called cryptozoospermia. If 2 or 3 cryptozoospermia tests are positive, then it is time you send him to an andrologist, and this is where these parameters will come into play. The volume, the pH, and it will tell them the functional capacity of the accessory glands, the testicular size. We used to get those orchidometers. I don't know whether we still practice it or not. Testicular volume, the hormones at that time, then they pep up by keeping them on drugs. See, there is a spurt in spermatogenesis. If there is a sudden spurt, freeze those samples. If there is a spurt, ask him to repeat the test again after 10 days. Normalcy is available, fine. He got a much needed boost. Now the spermatogenesis is normal. Sometimes they may crash down again. So these are all the nuances which you have to take care. Sometimes symptoms of prostatitis mimic lower UTI infection. Passing of urine, very less. Feeling of voiding quite often. Burning sensation. Do a semen analysis, do a urine analysis. Pus cells in the semen, prostatitis, pus cells in the urine, UTI. Antibiotics do the trick. Large volumes, huge, 7 ml, 8 ml. Seminal vesiculitis, inflation of the seminal vesicles. Because both seminal vesicle and prostate are tall, columnar, striated epithelial secretory glands with a lumen. So whenever there is an infection, the secretion tries to wash it off. Or hemospermia, blood in the semen. Prostatic carcinoma, bladder carcinoma, or severe infection, send him to an andrologist straight away. So these are the other 3 things also which we need to see. General part, what is what in the semen? Now what we are doing, we are checking the cellular fractions, In the seminal vesicle, this is the contents, prostate, and an overall contents. And acellular is just seminal plasma, epidiasomes and prostatosomes, the secretion. So we are not targeting basically the seminal plasma as such, we are targeting the cellular fractions which are present in the semen. Okay? Yes, but seminal plasma toxicity is very important. Because if that is infected, the chance of those bacterial viral load accumulating on the sperm membrane is very high, just like AIDS. Sperm are clean because they are in the testes, blood testis barrier, so AIDS virus doesn't directly affect them. It is the collection of the AIDS virus in the seminal vesicle secretion and the prostatic secretions which coat the sperm with those things. You got my point? That's why the wash, it is intended to completely capacitate the sperm, eliminate the seminal plasma, activate them, increase their, what we call it as ionic receptivity of calcium ionophores on the acrosomal head, make it highly activated, so it is forced to be attracted by the cumulus cells of the metaphase 2 oocyte with a high receptivity, and thereby start the first reaction which we call as the highest reaction. Okay? And then starts the membrane reaction. So these are just volume related points. pH and its importance, very important. But please check the pH within 10 minutes of collection, because the amides and the amines present in the seminal plasma on contacting with the air get oxidized, and it will always show a alkaline nature. Reasons why alkaline, why acidic? Viscosity, well, inversely proportional. In a woman, estrogenic mucus, Lovelace spin-bar kit, more receptive. Non-estrogenic, brittle mucus, hostile mucus, it's like a chemical barrier. But in a semen, prostatic infection, viscosity increases, because usually seminal plasma is a coagulum secreted from the seminal vesicles, which is broken down by the PSA present in the prostatic secretion. So after 15 to 20 minutes, normally, even a viscous sample becomes normal, or natural liquefaction time is 5 to 10 minutes. But if on the day of a procedure, if the sample turns out to be viscous, don't wait for it to get viscous in a normal way. You are increasing the time of the contact of sperm with the seminal plasma, thereby decreasing its fertilization potential. So do a very delicate needling through a 20 gauge needle. Don't worry, sperm won't be damaged by the 20 gauge needle. That's usually the questions come up. So this is viscosity, very important parameter. We measure the viscosity in the term as poise. 3 to 7 centipoise is the normal viscosity of the human semen. Okay? Odor, as we discussed. What could be the reasons for? Color. Fine? Now count, as I told you, million per ml, million per ejaculate, and total motile sperm count. Please, all the three. Just being present doesn't mean that it is effective. This is just the text form I have given. This is how we measure. So when we discuss in the lab setup, the importance of your bench microscope or your compound microscope, motility, how we used to grade ABC, initially as to how they progress, how they zoom across the eyepiece. The faster they move, the difficult it will be to see the tail moments. Something like a progressive, linear direction, non-progressive, haphazard direction. Now, linearity means what? If I draw a straight line and a sperm tries to go through here, usually what happens, it goes like this, it never goes absolutely straight. Now, the more it deviates from the line, the bad is the motility. So, linear and motility, two different issues. All active forward sperm should be linear, but all linear are not active forward, basically. So, this is just how I have told the speed of the sperm. Attachment, denudation, membrane reaction, penetration, decondensation. Gradation, old methods. Now, yawing is important. Now, what is yawing? Yawing means a body travels in a straight line. But one plane always changes. In a sperm, the head always goes like this. This will be a negative yawing, because this action is important enough to attack or to denude the cumulus cells of a metaphase 2 site. Once the connection takes place, the sperm is activated by the calcium ions. The desmosomal junctions are broken thanks to the hyaluronidase, which is liberated from the sperm acrosome, because sperm acrosome is like a membrane. First is the glycoprotein layer, which gets removed during washing. They get capacited. Once that capacitation takes place, attachment, hyase, second step. Then penetration. Then in the perivitelline space. Then the entry. Now, when we count, these are usually the chambers today. Advantage, monolayer of the sperm, because when we use a slide and a cover slip, if the drop is thick, there are multiple layers. So what this ensures, there is just a monolayer which will help you justify the sperm in a clear-cut level. We can see in 20x, which we'll see in the afternoon, and this is sperm as seen in the 10x. Alternative was what? Newbar's chamber. And what we used to use over here? Semen diluting fluid, right? If somebody has used it. Now what does semen diluting fluid contain? It contains dilute formalin to make the sperm non-motile. Whereas even in a macula, to make the sperm non-motile, we have to incubate it for 5 minutes on a 50 degrees water bath. Because if they are moving, you cannot see how many grids they have occupied. So this is exactly what happens in capacitation. Hyperactivated motility, when you capacitate during a wash, irrespective of the procedure, IUI, IVF, ICSI, these are all the chemical changes which take place, and what do they result in? They result in an enhanced acrosome reaction. An acrosome reaction is a backbone for a successful fertilization. That's very important. Irrespective of the concentration or count, because at that time the quality of the individual sperm plays, because ultimately fertilization is done only by a single sperm. All the rest of them contribute to the zona dissolution. Now when we wash, there are two techniques. Of course, we'll go through in detail when we do it, but just to know. One is a natural selection, what we call it as a swim up. This is the principle, usually in normospermic samples. Logic is natural selection of the sperm, no trauma. But in this case, you have to do the washing twice. First, dilute the seminal plasma, spin. Second wash the pellet, layer the pellet, incubate it. The best of the best sperm will zoom from the pellet, which we catch it. It is swim up, natural selection. The only thing where we have to be careful in this procedure is the RPM of the centrifuge. Now foreign books will write in RPM, G-force. Indian books write in RPM, both are different. 300 G is equal to 1300 to 1500 RPM, and don't exceed for more than 10 to 15 minutes, because greater gravitational force will traumatize the plasma membrane of the sperm. And if the plasma membrane gets traumatized, the fertilizing capacity is literally zero, or I would say the cell viability is zero. So please, time and the RPMs, very important. Just like in a media, the temperature is important, because in media what you are using HIPPIS-based media, which is sperm salt substrate. So never keep it in a CO2 incubator, always a plain incubator. That's why setting up of an IUI lab is comparatively cheaper than a CO2 lab. Because CO2 incubator is coming to the tune of 7 to 8 lakhs compared to a few thousands which you have a plain incubator. Now, poor quality sample, double density discontinuous gradient, the devil from the devils, ideally used in ICSI. This is the principle, and this is how we exactly go through it. Different layers, okay? It's a selective filtration under pressure. The G-force acts. Excellent quality of the sperm will be collected at the bottom. Why they are the best? Because they will be morphologically the best, and the density of these sperm will be more than 1.10. So they are the best as far as result-orientedness is concerned. So for ICSI in an OAT sample, this is the yardstick. Or I could say this is the backbone. Even in a normospermic sample, you can use this procedure, no issues about it. General, please judge the sample. It's not a textbook says so I have to do it. Use your common sense. Interpret the sample properly. Select the technique, justify the time. Select count, million per ml, ejaculate, recover. What you need to do in a recovery rate is the best. Okay, fine. So this is your target. Aim for the maximum recovery rate. This is what you are going to achieve. ऐसा नहीं होना चाहिए कि the original count was fantastic and the recovery rate is pathetic. Your technique is at fault, your media is at fault, your pH is at fault, your incubation is at fault. Now most important, morphology, decorative or informative. We stain, and we stain on which principle? Acid base. Nucleus is acidic. It is stained by a basic hematoxylin. Vice versa for the seminal nucleoplasma or the cytoplasm. The tail, dense part, stained by OG6. You do your pap staining techniques, right? The same principle is there. When in vaginal cytology and cervical cytology, you do the pap stain, the same principle is over here. So these stains will penetrate the cell and give them shape precise. So according to that, you can justify them. So this I can just show you, which according to you is a normal looking sperm. Any idea? Usually in simple labs which give reports within 10 minutes, all sperm which are motile are normal. You must have seen that. So the abnormal count comes only 2%, whereas actually it's the inverse, the normal count is 2% or 4%. See, according to this text, only 4 is near normal. Now see, there is a vacuole over here, there is abaxial placement, the shape is funny, swollen midpiece, even swollen midpiece, acrosome improper, vacuoles, nicked part. Like that, if you cherry pick, none of the sperm will find normal. Now this is in case of normospermic sample. Imagine the case in OAT. And we want them to be a miracle worker. And the sad part is what? These abnormal ones swim the best. Like pinheads, they literally dart across the field. Of course, pinheads, so this one I'll show you. See, multiple defects. Now this is a pinhead. Now these Charlies move the best. So what we feel is, they are the best sperm, excellent motility. So if morphology was not the parameter, by this time, our population would have exploded 10 times more, because every sperm would have fertilized, and there would have been no IVF labs present in the world as such. Okay? Now, this is the reason why the stress factor is there. Now, many a times, young couples today, they marry at the right time, but they want to start a family later. Personality development, job professionalism. So, नहीं sir, अभी तो नया job है. After 2 years, अभी मेरा husband का नया job है. After 1 year, अभी तो नया घर लिया है, EMI भरना है. Then suddenly, overnight they want to become pregnant. Why? Because the taunts, insults from the parents and the relatives is huge. They can't take it anymore. But the sad part is, they want to become pregnant overnight. And you know, a watch pot of water never boils fast. You know that. You boil milk, you keep on looking at it, the bloody thing never comes up. But you keep milk, you turn back, it spills up. So when this thing doesn't happen for 1 month or 2 months, they get terrified, they rush to a gynecologist. It used to happen at our times also. We used to counsel them, nothing is wrong, give you 2 months more trial, are you treating me or I'm going to another doctor? Now we don't want to lose a patient. Ayo karalo. So this success, the moment you tell them, this inhibition is out. So this is controlled by your hypothalamo-pituitary axis, because in hypothalamus, there are 2 cells, supraoptic and paraventricular, which secrete the releasing factors, which target the anterior pituitary. They secrete gonadotrophic hormones. Now exactly adjacent to those cells are the centers controlling the depression. So these patients are many antidepressant drugs. So they suppress the secretion of those releasing factors, or the whole axis gets disturbed. You got my point. And the last is the Sertoli cell, in which the sperm are produced. So it's like a mold from which the sperm are spermiated. So when this axis gets messed up, finish, the quality deteriorates. Now here we are lucky. We are able to see the type of sperm. But what about oocytes? Even the ladies, when under tension, they have missed periods, scanty periods, delayed periods. Now tension can be temporary or permanent. Now this is like a permanent tension stress for them till they become pregnant. Or I would say till they have a live earth baby. But in temporary tension, what it was when we were students or in colleges. June, July, August, merry time. October, November, December, college day, rose day, fun-filled times. Come November, come January, February, prelims, oh shit. We decided two year chapter ka notes bana, 2 year chapter ka notes bana, then we amalgamate the notes. So the last day, 2 days before the exams, your tension was sky high. The food was tasteless, none of the TV programs were best. But the moment the last paper you give, it is out. The parents used to ask, kaisa gaya paper? Arre, bahut acha. I don't think any student has told the parents honest ke mera paper ekdam bakwas gaya, because it would give tension to them. And ultimately they would give them the back tension. Sala padta hi nahi tha kuch. You know, it's like that. So this is the concept of tension giving. That's the reason in counseling, please give hope to the patient. Agree, howsoever you may feel it's a hard nut to crack, but still, always give them stress. Believe me, that will enhance the patient-doctor receptivity. Not only that, they will promulgate your name to the other patients as such. नहीं तो क्या होता है? ए भाई मत जाना, पहले दिन से डोनर की बात करता है. अरे पहले दिन में 80,000 ले लिया, क्या करूँ? Whenever, so you have to show the breakup. So don't, and in an infertile patient or any patient, never take a yes instantly from across the table. Believe me, they will go home and change their mindset. फिर फोन करेंगे, सर, I think hard time मिला नहीं, next ये टाइम पैसे का बंदोबस्त नहीं हो सका है. फिर नेक्स्ट टाइम भी नहीं आएगा तो आप फोन करोगे, लगाना उसको फोन कहाँ गया हुआ, बराबर कि नहीं? It happens as that because we are also equally in need of patients. Let's be honest. Now look at the promulgation of centers. I think when I started with Madam in 2009, there were hardly 2 or 3 in Nagpur. Now how many are there? I think it's better not come to that conclusion. It will depress us further. Okay, fine. So this is the effects part, different parts. Now sometimes it happens, huge count, motility is poor. Does that mean that all the non-motile ones are dead? Or a non-motile sperm can be alive and still be non-moving? So this is because of depreciation of micronutrients, temperature effect, effect of ROS, and excess of smoking. So this we detect by nigrosin staining technique, nigrosin eosin. The sperm which are colored are dead, because the sperm membrane is broken and the stain has permeated. Now on the day of an ICSI procedure, you cannot do staining. So there is a test called HOS test, horse test, which will allow the sperm to curl the tails because the sperm membrane integrity is intact. Then you select those sperm and inject it. Correct? So this is called the test for sperm integrity in case of OAT patients. So the best thing is even in the worst of the worst OAT sample, what you should see is the sperm should show some twitching. Twitching means what? Membrane integrity is intact. And in any cell of the human body, as long as the activity is there, the cell is viable. It may be slow, it may be bad, it may be grade 3, but viability is present. Okay? Now this is another, I won't say a fad, but a add-on, which has taken up the infertility people by storm. DNA fragmentation, DNA fragmentation. Agreed. But it is one of a parameter which will help you indicate that this might be one of the reason. It is not that this is the reason. Because just like varicocele, mild to moderate DNA problems are there in every males. It is only when they reach a certain threshold, we can say, this could be a traumatic part, so you have to modify certain blah, blah, blah. Now today in any damn thing, अरे lifestyle change करो यार. That's common thing we said. कभी खाते हो, कभी पीते हो, खाने का time change करो. क्या खाते हो? अब ऐसा सब change करोगे तो मैं जीऊँगा कैसे? Because today with the clockwork style of life, it's not possible for us to modulate everything. Agreed? Because what happens is, I'm not talking about sperm. I'm talking about any goddamn cell. Anybody under stress will go under oxidative stress, and it is in that oxidative stress, what happens is that these chromosomes get messed up because The topoisomerases, which are nuclear enzymes, they get stressed out. So when anything under stress, a cell when it is undergoing stress, what does it do? It will try its level best to survive. So its organelles will show hypertrophy. Like your mitochondria will swell, it will degenerate, the nuclear plasmic reticulum will be completely shattered. This is called work-induced hypertrophy. Now in the case of nuclear work-induced hypertrophy, this is the damage. Single strand and double strand, because these topoisomerases are affected. So this can lead into a single strand or a double strand. These are the indications. Now these are the quite same as OAT sample. ICSI के जो indications है वैसे से मिलते जुलते हैं. Basically, because it's the only test but which deals with the DNA aspect in the acrosome. But there are lots of hiccups to it. Of course, I have got a big PPT, but I will just cherry pick the slides. Now, oxidative stress, yes, it is reversible. Chromatin abnormal packaging, unfortunately genetic, so it's irreversible. And apoptosis, apoptosis, natural cell death, unavoidable. A person has to live with it. Cherry pick a sample. So maybe after multiple attempts, maybe that one lucky sperm from a huge coagulate of compromised sperm can do the trick. I think in our relatives years ago, we used to have somebody, na? Arey 7 saal hue bachcha nahi hua, suddenly one fine day I'm pregnant. We must have had such instances. So on that lucky day, that lucky sperm was able to do the trick, but the sad part was by that time the lady has aged. So then the 2D, 3D detection, fetal deformity, that's another cup of tea. Now see, in a nutshell, I'll explain to you. When a cell gets stressed, now it's a nucleus, you unwind it, you get a chromosome. Watson and Crick. DNA, protein core, and chromatin. Chromatin you unwind, histones, transition proteins. So these toroids are the ones which are the least packed inside. They will spring out their certain filaments when they are compromised. It's just like a lady tying her hair tight sitting on a bike. At the end of the ride, few or 3 strands do come out. So these are the ones which are traumatized by the air current. The same is the case in DNA. Poor packed, because I tell you in the next one, see, we have got protamines and histones. In many species, 95%, 85% is protamine, but sometimes in human, it is less. And histones are more. And histones are more susceptible to damage. So any stress will make the histones appear and your sperm DNA integrity is compromised. But at the same time, if vis-a-vis the female partner is young, there is a self-repair mechanism. So the prognosis is better if the female is young. Now these are the 2 essays. I think I'll skip this. Now see, there are many methods. One was tunnel. Sab log bolte hain. This is the full form. It's a very mile-long form. Not possible in our labs. Even comet is not possible in our labs because they are done in case of what? Dairy industry, thoroughbred industry, horses, good quality semen. Okay? Not possible. This is what we are doing in our labs. SCD method, where we fix, decondense, stain, and interpret the slide. And this is our general index. What should be seen when a DNA report comes? It is subjective to many parameters: human interpretation, staining methods, the type of the stains used, the alcohol used. So you cannot say with authenticity that sperm DNA is bad, so you are infertile because of that reason. Because for a take-home baby, there are more than 160 parameters, out of which we are able to monitor only 30 to 35. That should be the last ones, I presume. So this is in a nutshell, or I have pulled all the tests together. What are the shortcomings? Okay. Just testosterone dips. Age, very important. Sometimes we see in papers, Karishma Kudrat ka 75 years pe pita bane, mata bane. But ab aata hai na kabhi kabhi. No, we see the papers and they take pride in displaying that. But sorry to say, many times by the child is 1 year, one of the parent conks off. So who's going to breed the child? So nowadays, as per the guidelines which ma'am will be telling you, there is an age beyond which, a collective age of the parents, you can't do an ART procedure. Correct? Sperm will be produced. Quantity, but poor quality. Just a representation. Okay? And this should be my last slide.